tonight. It is my absolute pleasure to introduce Everett Maroon as our guest this evening. Everett is the executive director of Blue Mountain Heart to Heart, which is a local agency. Here, it has an office here in Walla Walla, but has offices in 3 different Washington counties, serves 7 Washington counties and 2 Oregon counties. It's an agency that focuses on providing case management and support to stigmatized patient populations. We're going to learn a lot about that tonight. Everett is, as I said, the executive director of this agency, also a commissioner on the Washington State LGBTQ Commission, and a super proud dad of 2 amazing children. And I learned today, this was maybe the highlight of the last 24 hours, maybe the last week, is that Everett is a best-selling author. He has a memoir, also has a best-selling series for young adults about time travel. The first title is The Unintentional Time Traveler. So I have my reading cut out for me for the next month. Hope day. I don't know. How long does it take to read a book in quarantine? Anyway,
it's not that
there
long.
it is.
It's not big. It's
not that big. That's like 3 months in COVID. All right, thank you. And yeah, show us the cover again. Sorry, I'm just so excited about this book. Unfortunately, not the topic tonight, but if I could do it.
We could totally do it though if you want. I have my little reading thing.
Welcome everyone. A bit of a surprise, a little twist, if you will. Next time, we'll do that next time, Everett. Thank you. All right, well, so it's, again, welcome to all of our friends who have joined us. This is Everett. And over here, my friend Zidane. Zidane, do you want to say hi? You want to introduce yourself?
Okay. Sure. Hello, everyone. Yes, I'm back once again as the coordinator for the Neighborhood Engagement Program at the City of Walla Walla. And we are happy to, again, be collaborating and, being a co-sponsor, I guess, feels fancy, of Walla Walla Speaks. And I'm so happy to be here with Everett to have a heart-to-heart about Blue Mountain Heart to Heart. And especially on this Valentine's Day weekend, let's just keep this all close to our heart. So.
Oh, perfect.
Yep. Wow.
Thanks, Zidane, for bringing it home. Now we're ready. It's been teed up for Everett to take it away.
And I have no puns. I'm not gonna.
It's been taken care of.
Yeah. I'm gonna start off by saying my mother was a very proud Methodist. And that she spent the last 25 years or so of her life in Eureka Springs, Arkansas, and was one of the people that really pushed hard for her church to become a reconciling congregation. And that worked really well for them. They grew their membership congregation by a lot. She said it was a beautiful thing to look out during service and see young families, multiple generations of families attending, and they did a lot of really good work, and I'm super proud of her. And she's been gone a couple of years now, but I just thought, from one Methodist to another, I would tell you all about that. So, okay, so back in 2008. I got married to this lovely person who got a job at Whitman College. And I was very unenthusiastic about the job that I had working for the Social Security Administration. So I was willing to move out to Walla Walla from Washington, D.C. on this crazy adventure with her. And that was right when the credit market and the housing market and the everything else market went kaplooey. So I didn't have a job. I thought I'd get out here and be, hot stuff, and nobody wanted to employ me. So I took a job well beneath my so-called station in life as a part-time grant writer for this scrappy but struggling nonprofit, Blue Mountain Heart to Heart. They had missed grant deadlines. They were getting rejections for grant applications that they did make because people thought that they were about to go under. There was talk on the board about, potentially shutting their doors. And, if you've served on a board, you should never, ever let that message go out into the public. So I had worked before Social Security on at another firm in DC, in Bethesda actually, and I'd probably written about 300 grant and contract applications for that job. That was my whole job, 70 hours a week. Also horrible. Um, but so writing grants, little grants, that was like, didn't scare me. Um, and we won a couple of things. We got a contract expanded from $28,000 a year to more like $60,000 a year, which let us have some more hours to do work. And there was a lot of like little building. And 6 months after I took the job, the executive director left to go work for the VA. And they said, Everett, could you be the interim? And so I said yes, because what else was I doing? you know and I thought it's a good place, and I had gotten to know some of the clients, all of whom had HIV or AIDS, and didn't feel like they had a lot of other support. So kind of wormed its way into my heart. And I had been in ACT UP in the early 90s, out in when I was in college and graduate school. And it was an important issue to me. I lost some friends back in the early 90s to HIV. So, I could feel good about the work that I was doing, but I don't think I was a zealot for it initially. Um, so I became interim director, and I was getting to know the clients more, and I was getting to know the couple of staff members that we had. And I could kind of see we ran this. There had been since 1998, Blue Mountain Heart to Heart had run a syringe services program. That literally means that we hand out clean syringes to people who inject drugs. What people will disparagingly call addicts. And the point of doing that is so that they don't transmit HIV to each other by sharing used syringes, and they don't transmit hepatitis C to each other by doing the same. It's really, really good at preventing transmission of infectious disease, but it was not a program that we kind of stood on the rooftops and shouted about. It was very quiet because everybody was afraid. If people know that we do this, they're going to resist, and they're not going to give us money. We already can't bring in the kind of money Humane Society can bring in, because what is controversial about a puppy or a kitten? Nothing. Nothing is controversial about a puppy unless it's pooping on your living room carpet. Um, so, you know, but I could see people coming in to get syringes, and we had nothing else to give them. And people would come in with HIV, and there's a whole state apparatus to help them. Same issue. We don't want them to transmit HIV. That's why you get medical care access. That's why you get health insurance. This was before ACA, before Obamacare. You still got insurance if you had HIV in Washington State. Didn't matter if you were a citizen. Didn't matter if you were an undocumented person. Didn't matter if you just walked in and declared your residency the week prior. You still got insurance and access to medication, because public health saw that it was really important not to let HIV spread to the rest of the community. And if you get people on medication and you lower their viral load of the virus, because we can't cure it, right? But you can make it so that it's no longer in their circulation. It's in their tissues. It finds a deep reservoir in tissues like the brain, the kidneys. We can't really get it out of those places, which is why we can't cure it. But if it's just stuck in those locations, they can't transmit it to anybody else. So they got all kinds of support, but people who were using drugs didn't get any support. And you can't sit there and argue ethically, well, just get HIV and I can do more work for you. No. So to me, this created an ethical and moral dilemma. How can I sit there and watch, um, 600 people who have one particular chronic disease destroying their life, and not do everything in my power to help them, when I can do that for these, at the time, 25 people? Um, so I took some steps. At this point, I had become the long-term permanent director, which was the fault of that board. Um, But I decided we needed to think about public messaging. We needed to strategize with the board of directors and me. We needed to get more involved in behavioral health and figure out what are the resources around people who are using substances? What are the resources around people who have co occurring mental health disorders? Because often those things are in relationship to each other. How can we change our contracting? What other kinds of dollars are out there to help people? At the same time that we were asking these questions and thinking about the overdose death rate in Washington state was doing this, just climbing year over year. We got to the point in the United States where in 2020, 81,000 people died last year of drug overdose. And I know it pales into comparison with COVID-19, but that is a once in 100-year pandemic. We created this problem with opioids by overprescribing. By 2007, we were prescribing 104 million daily doses of opioids in Washington state. We have 7 million people, 104 million daily doses. So, worldwide, when we look at folks, no matter what their racial makeup, no matter what their nationality, or where they are in the world, about 33% of them will become addicted to opioids between 4 and 7 exposures to narcotics. So think about people who have their wisdom teeth removed, which is most of us. In the United States, until very recently, we would give you intravenous Valium for that, and we give you a box or a bottle of hydrocodone or OxyContin for your troubles, send you home. 16 years old, 19 years old, 21 years old, and about 80% of people under the age of 25 who are addicted to heroin in the United States, their first exposure for those narcotics at wisdom tooth removal. So we don't need to do that. We created this problem. It's not a virus that we have to figure out a vaccination for, or a retrovirus that we can't figure out a vaccination for. This is a human-made disaster. We can unmake it. So we did become more vocal about syringe services because we wanted more people to use the service. While they're there, we do all kinds of things for them that, I think is at the time was kind of, dare say, cutting edge, or innovative. And now you see a lot of other syringe programs doing it because it's wound up becoming best practice. But we have a warm greeting in the beginning. We might be the only friendly face that person sees that day. So we give them a genuine hello. It's good to see you again, or it's nice to meet you if we've never seen them before. We offer them all kinds of other things. So not just trying to prevent HIV, that's the primary public health goal, prevent HIV and hepatitis C transmission. But the secondary goal is prevent all those things that happen to the human body when you inject yourself with a needle too many times. So abscesses, amputations, cellulitis, sepsis, vein collapse, extensive bruising, that kind of thing. So we give people alcohol swabs, we give them antibiotic ointment, we give them, cellulose pads to try and deal with tissue damage that they might have, Epsom salts, all those kind of. It's just you're walking into a medical closet when you come in. So we wanted to talk more about that so that people would know, there were some solutions there. Then we started giving out naloxone. That's a medication to reverse overdose. And we started that in December 2014. And we had our first reported reversal of an overdose in February of 2015. That first year, we had 18 overdose reversals. The next year, 32. The year after that, 45. Then we started doing naloxone as part of a statewide grant with the federal government. We were expanding our syringe services at that point into Franklin County and then Benton County after some controversy in Franklin County from the county commissioners who didn't want us to serve people who use drugs. We went up to 209 overdose reversals that next year. Then down a little bit to 199. I'm not really sure why. And these are all self-reported from people that get naloxone from us. But last year, during the COVID pandemic, 279 reversals, which was, a big leap. So there are not good numbers about how many overdoses result in death. I've heard anywhere from 7 to 20 on average, but just looking at a number like 279, we saved some lives. We gave people another chance. And I have often said that my job is to save people's lives and someone else can have the job of saving their souls, but that's what we're trying to do. So from there, we said, well, we've got harm reduction, right? Trying to keep HIV and hepatitis C at bay. We've got the secondary goal of, helping people deal with the sequelae or medical effects of their drug use. Let's see if we can go to a tertiary goal here and get people into recovery. Get them to stop using altogether. See if they're interested in that. We've built this level of trust with folks. What can we do to inspire them to maybe get out of this? And we know the science says that like tough love does not work. I do not begrudge any family member who is tired of having someone steal from them or be abusive to them, in saying, I have a boundary and I can't, you're going to have to take a step back, or I'm going to have to take a step back from you. I don't begrudge people in interpersonal relationships, that kind of boundary drawing. But for us as professionals, we're there to keep being there. When they have lost everybody, we are still there for them. And we don't give up on them because that's our role for them. So we got another grant and out of University of Washington, and we now have 2 low barrier clinics. That means you don't have to get a chemical dependency assessment. You don't have to jump through all these hoops or be clean for a week or whatever, because we see people can't do that. That's not the nature of this disease. So they walk in, and as long as they haven't used in about half a day, we can get them a prescription right then for Suboxone, and they can go and take it and start to get over their withdrawal symptoms and into recovery. We really, 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 really recommend that they get into case management with us, that they take advantage of the other kinds of things we have. We have housing assistance, food and nutritional support for people. We'll pay for yoga. We'll pay for acupuncture. We'll pay for chiropractic. If someone has an actual ongoing pain, chronic pain issue that got them into opioids in the first place, we want to help them resolve that as much as they can and turn them to other pain remedies than narcotics. So we're now working with folks who self-select because they're at the syringe sites, and then we have nurses and prescribers there to help them. We're in the jail now doing case management and Suboxone prescribing for people to get them into recovery while they're still inmates. And then we can work with them after release if they are going to release back to the public. And we're involved in this diversion program along with comprehensive mental health to try and get people who might have been in the emergency department 5 times in the last month, to help them get their lives in control. So our programs, we still are doing HIV work. We've also expanded HIV programming for folks. We're never going to leave that legacy behind, but it just was not morally feasible to me to ignore what was happening with substance use in our communities. So I've now finished 10 years at Blue Mountain Heart to Heart. I am, in fact, that zealot. I want to be a champion for these folks. I do have people in my family that have struggled with these issues. And as I said to someone earlier today, it didn't turn me away from them. It turned me more toward them because I know who the people are underneath this behavior, and I want them to be able to be their whole selves. So that's what we do.
Thank you, Everett. Well, I have some questions bubbling up in me. I could use a minute to jot down my ideas, and I imagine that our other attendees might want a second to think about what they've heard and what Blue Mountain Heart to Heart is up to and ask questions. Would you before I turn it over to Q&A though, would you tell us a little bit about what you guys are doing with comprehensive mental health, and is that related to the arrest and jail diversion?
Yeah.
Okay.
Well, as it happens, they are my landlord at the Kelly Place building because the county sold that building to Comprehensive, and we're going to be evicted out of there before the end of the year because Comprehensive is turning that whole first floor into an inpatient um, chemical dependency and mental health facility. So I got to find somewhere to go, but that's an issue for another day. But yes, I found out about the law enforcement assisted diversion, the LEAD program, from a friend of mine that I used to work with on another grant a few years ago. She now works for the National LEAD Bureau, um, and said, nobody from east of the Cascades applied for the first round of funding for these diversion programs. So we only have two in Washington State, one in Olympia, and one in Grays Harbor. And what do you think about applying to be the first east of the Cascades? And I said, I don't know. I believe in diversion. I believe in, that police and sheriff's deputies are overextended, that they're not properly trained to deal with people who have substance use disorders. They're trained to deal with people who are affirmatively breaking criminal code, and doing something violent or doing bad things, not just drugs. Um, so I said, I don't know if I have that relationship with law enforcement that I need, but I bet Comprehensive does. And they said, well, we don't usually award these to multiple organizations, Everett. Why not just have Heart to Heart do it? And I said, well, you know, you're coming to me and you're saying, gosh, East Side people didn't apply. One of the reasons is because none of us are really big enough to tackle these enormous contracts that you guys think up over there in Westworld. So you're either going to take both of us bidding together or we're not going to bid. And they stopped complaining. And, Regina and I met and really talked it through and said, could we have two comprehensive employees as case managers and two Heart to Heart employees as case managers and have them work on one team? Who's done that in Walla Walla? Um, why not? Why not do that? So Comprehensive could bring to bear their crisis team and their on-call service, and they're a $95 million nonprofit, right? We're a $2 million nonprofit. So we had some differences in terms of cultures. We certainly had differences in terms of liability and insurance, and there's all this stuff around confidentiality and how do you move data, how do you actually share clients, who's um, who's got the authority when someone signs a release of information. Can they sign a release of information simultaneously to two organizations? Yeah, they can. So we had some logistics to sort out, but we made our bid, we won it, and we're in week 6. So yeah.
What do you do?
What do we do?
Yeah.
Oh, so our initial caseload, we asked Walla Walla PD. So Captain Brayman came up with like a list of 20 people who are what we call hyperutilizers of the jail and the emergency department. But that's not really how LEAD typically works. So we were kind of like, our case managers are cold calling people. Hey, we have this program. Would you rather be in this program or still subject to all the penalty? The prosecutor will release you from these charges if you enter this program. But typically how LEAD works is you're caught with contraband, right? You're caught with some illicit drug. And the officer kind of sizes you up. If you're not also doing something violent or doing something felonious, then you can be put into our program instead of booked, or arraigned at the jail. And if they're not sure, they can like bring that person to Waypoint and one of the case managers, there's always two case managers on at all times. Well, from 7 in the morning until 8 at night. After 8, then there's the crisis team at Comprehensive to help deal with calls. But if this is like someone everybody knows, and so they don't think you're going to be a flight risk, what that officer will do is say, okay, you have this appointment at 9 in the morning tomorrow. Um, and case manager is going to come to your house and talk to you, and then you can be in this program instead of me taking you to the county jail right now. Um, so that's kind of how that works. But there are other people who can do like a social referral as well. So child protective services, DSHS, a shelter operator, for example, could all refer people into the program for the same kinds of reasons. Witnessing the same kinds of behavior. So then those 4 case managers, will confer. We will check in with law enforcement and city attorney and county prosecutor and say, does everyone agree this person should be in this program? We go through that list every 2 weeks and give them updates on everyone who's on the caseload. So that's how that works.
Well, okay. Well, week 6. I'm excited to hear more about that and how it's going. 6. Congratulations, 6-week anniversary. All right, friends. Well, let's take a second to gather our questions, and you can start submitting them there down at the bottom of your screen with this chat button. Send them to us, and we will answer them. I mean, Everett will answer them. I might read them
You
aloud.
might know the answer. I don't know.
I might know an answer.
Depends on what they ask,
While people are coming up with their questions, I have a vague memory from Richland that over in the Tri-Cities, we had something called maybe drug court. So if you had been arrested and charged, maybe an alternative to serving time would be to enter treatment.
Yep.
This catches people even earlier, though, the LEAD program, right?
Yes. Well, it depends on the person and how many times they've been through. So sometimes they call it therapeutic court. It's more structured. So the judge is working with those individuals instead of a case man. I mean, there's still a case manager in the scene, but the judge is the person kind of saying, all right, Sally, we need you to do this, this, and this. And I want to, next time you come back next month, I want to hear that, you've achieved this goal or something like that. So it's really more, whereas LEAD is like, if you're not ready to get into recovery, you don't have to get into recovery, but you need to stay engaged with us. We keep seeing how you're doing. So how many clients? We have 24 clients in the caseload for the LEAD program right now. I think in our low barrier programs, we have about 70 participants. For Ryan White case management, we have about 40 folks. So that's where we're at.
Low barrier that's folks who are referred by like shelters and things like that. What's low barrier?
Oh yeah. So the low barrier buprenorphine clinic, basically. So buprenorphine is the generic name for Suboxone. And Suboxone is actually 2 medications. It's buprenorphine and naltrexone. Pregnant people cannot take that naltrexone, so we give them Subutex. So I just say buprenorphine because I know that's what people are actually getting. And low barrier just means you don't need to jump through all those hoops that take 2 to 4 weeks in our area to clear. You can declare that you want to start recovery right now, and we'll do a clinical assessment and basically what they call COWS. So it's an assessment of your withdrawal symptoms, and we'll do the SBIRT, which is an assessment of your suicide risk. So if you're, we're happy, the clinician is happy with all of that, then you can get going and we'll prescribe.
Julie asked a great question here, and because not all of our attendees can see the question, I will read it aloud as if I were Julie. Everett, what was your learning curve? How high was your learning curve for the medical pieces of your position?
Yeah, I'm gonna say years. In 2013 is when we came out with our last strategic plan before the 2020 strategic plan. And that is when, after having our annual retreat, that the board and I decided we were going to deal with opioid crisis response. And it started out as just like, what else can we do with syringe services to help, because no one else wants to do that work. So um, from there, then we got into overdose reversal, and that's where medical pieces started really kind of starting to come up. Um, there was some push in the 2015-16 kind of nationally for syringe service sites to start doing wound care clinics. But to do a wound care clinic, you need to have malpractice insurance, or somebody who's going to come in and do it has to carry their own malpractice insurance. Because what if that wound continues to get worse? Somebody can sue and say they got bad medical advice. So, at that point, I really kind of had to dig more into the medical stuff. And obviously, I'm not a medical practitioner. I don't pretend to be one. I do have a medical assistant certification in order to do HIV and hepatitis C testing. I cannot even give vaccinations with that certification. So, it took a while. I sat on a lot of, webinars and committees and work groups and just learned and sucked up everything I could. Um, And then Chuck asks, can you share some success stories that keep you going? Okay, to be general, to keep confidential. I appreciate it, that Chuck. Thank you. Um, one day, a woman walked in to get an HIV test, and she was very nervous. And I mean, nobody walks in to get an HIV test with bravado. Everybody walks in with deep, deep shame, embarrassment. They're so mad at themselves that they even, were potentially exposed. And I could be a stranger who's about to give them the worst news of their life. And so I take that moment very seriously. I don't want people to, you know, to feel like they're all alone. So she was telling me about this abusive boyfriend that she had, and that he had like many women who come in, that the male partner had been unfaithful, and they had been used to not using any protection, because her assumption always is that they're a faithful partner. They might be married or not, or long term or whatever. um, but there's a window, or there was at the time, for the test that I was using. It had to be 3 months before, because this was a rapid test. And so while it was very accurate, it wasn't extraordinarily sensitive. Those are two different aspects of test kits. So I needed like 3 months, and she only had like two. So the chances were that it would come back indeterminate or negative, and I didn't want to give her a false negative. So, the guidance is to tell that participant or that client to come back in a month. Um, and so I couldn't test her that day. And I said, but I want to see you. You need to come back. But before you go, I'm just going to tell you, you don't deserve to be treated that way. And I don't know why I said that. It's none of my business, you know, but I said it. And then I didn't think about it. She, left, and she didn't come back the next month. She didn't come back 2 months later. But 7 months later, or something like that, half a year goes by. This person walks into my office, and I am pretty face blind. I'm really bad at remembering faces. I didn't know this until I was in my 30s, but apparently I'm really, really, really shoddy at recognizing faces. I need the name, and I need the context and all that other stuff. So she walks in, and it's just a stranger walking in, and she says, "Can I hug you?" And this obviously pre-pandemic. And I was like, "Okay, well, So I give her a hug, and I said, "What's up?" You know, and she said, "I was in here, almost a year ago, and you couldn't test me, but you listened to my story, and you told me that I didn't deserve the abuse I was getting." And I said, "Oh, well, that sounds like something I would say." you know. And she said, "Well, I want you to know that I left that guy, and I'm only using like a quarter of what I used to use in terms of the drugs that she'd been using. I'm in a nursing program, and I'm getting visitation back with my son." And I was like, "That's tremendous. It's wonderful. I'm so happy for you. And she said, it's because you said that. And I was like, no, it's because you decided you had enough. It's not about me. Take your own power, and congratulate yourself for deciding you were done, And I never saw her again. I don't know what happened, but you should just be honest. Put yourself out there. You never know what people are capable of. And they got to give themselves the grace and the opportunity to do something different. So that's my story for you, Chuck. I hope you liked it. Is the number of clients rising or falling? Asks Shirley. Rising, definitely rising. The number of clients who were in recovery who relapsed since COVID definitely also went up, but the vast majority of them attempted to get back onto medication right away. So I'm very proud of them for doing that. Yeah, definitely number of clients just keeps going up and up. But they're new people. I mean, in some of the programs, they're new people. So that's good.
So I am curious. I know that your guys' job at Heart to Heart is to catch the people and to do your best to keep them alive.
Mhm.
But what do you guys think about like the source of these problems? You talked about this
Mm.
overprescribing problem and how, I mean, how's that changing? The 104 million daily doses is what year was that? Is that
That
this
was 2011. 2011. In 2007, a group of physicians got together to start looking at what the daily prescribing was. And at that point, it was already like in the high 80 million range, low 90 million range. And it peaked at 104 million in 2011. But don't rest on your laurels, because the latest figures that I saw were still in the mid 90 million a day doses. So I think, there's a long way to go. I mean, once we opened up this Pandora's box, it's just really hard to, put everything back in there. But, we keep trying. There are things that have changed. Prescribing has changed in the United States. It's maybe even swung a little bit too much the other way. There are people with chronic pain who now really can't get very good access to narcotics. But for sure, surgeons, um, and dentists accounted for a lot of the overprescribing, and they have really, really ramped down what they give people post surgery and for dental procedures. And I think that's a really good thing.
Yeah.
Yeah.
Thank you. David asked a good question. How can the community help advocate for you and your work? What can we do to help?
It's a really good question. I'm so used to just like treading through with, you know, well, one thing is if you hear someone talking about a person who uses drugs in a demeaning or dehumanizing way, you can remind them of that person's humanity. That's somebody's son. There, but for the grace of God, go I. I mean, it really, um, my mother, I grew up hearing that from my mother all the time. Um, I think another thing people could do, um, if you know someone in trouble, send them our way. One of my sort of jokes is like, if you're doing drugs in Walla Walla County, you're eventually going to run into my ass. Um, I'm going to find you. Good news is I'm going to try to help you. Um, but just referring people to us or telling them about our programs, you never know who needs to hear that. And I take a lot of phone calls during the day from concerned parents, concerned partners, people themselves who, you know, um, aren't even sure they can really get into recovery. But I say you'll never know until you try. So come on by and come talk with us, and we'll, if nothing else, you'll have some information you can use another time. So That'd be great. And we do have a wonderful website where we take your donations, so you can always do that too. But I think just trying to demythologize drug use, um, help people get to that place. Um, in that, it's this whole theory called states of change, and we need people to get to that place where they're really ready to make a change in their own lives, and we just can't make them do it before they're ready. um, we don't currently offer treatment for hepatitis C, although we don't not offer treatment for hepatitis C. Thank you, Fitz, for your question.
It's from Bill.
um, we'll certainly is someone that we're working with through the low barrier program or another program, knows that they are um, hepatitis C positive, or they took a test from us and got a confirmatory test somewhere else, we can prescribe the hepatitis C. Nadine Pulver, our physician assistant, is fully trained on how to help administer that medication. Um, but we are often talking with folks who are homeless, and it's hard for them to manage meds that are, like in a Z pack that might have to be refrigerated, or that are more complicated to take. Um, but it's not something that we're saying no to. I am trying to get a grant so that we can buy some Hep C medication, and then we could, for example, go out to the sleep center and administer it to people who need it, until they're done with their course of treatment. So that would be a cool thing. I'd like to do that.
Beth had a good question. Do you refer to 12-step programs, and what role do you see them playing?
Thank you, Beth. Great question. Um, Many people who are long-term users of substances have already been through 12-step programs, or have court has told them that they have to attend groups like NA or AA. And so they're kind of already in those programs before they even come to us. um, I like to say that all of our programs are evidence based. I cannot say that about 12-step programs because they're not technically evidence based, although they're very um, helpful for a percentage of people that we're trying to serve. So I don't get in the way of 12-step programs, but I do tend to work with one-on-one counselor referrals. There are a couple other models of group therapy organizations that are here in Walla Walla, and some of our folks get involved with them too. But I do think in particular that the mentor or sponsor relationship can be really helpful for folks. On the other hand, um, it is common and maybe becoming less common, but still common in 12-step programs for some of those sponsors to say, if you're on buprenorphine, it's just another substance. You're still an addict. And I had one client stop taking buprenorphine cold turkey because her sponsor was not going. He said he wouldn't be her sponsor anymore if she continued, and then she overdosed. You know, like within 2 days of stopping using buprenorphine. So that made me a little frustrated. Um, so I think everybody's journey is different, and they're allowed to try the things that they think are going to work for them. So, um,
Lots of different roads to recovery. We just want to make sure that people are on theirs.
right. Chuck asks, you haven't mentioned meth. Is there any help for meth users that is getting positive results? Great question. There is no simple medication remedy out there for meth or psychostimulants in general. People are trying things. There have been there's some research with folks that use other kinds of stimulant replacement medications like Adderall and Ritalin, with folks who have meth addiction, the jury's kind of still out on those, but that research is continuing. The thing about narcotics and opioids is they're very close to our natural endorphin pathway. So we understand these drugs very well, relative to other kinds of drugs that people could be taking. Um, so we know really well where the receptors are in the brain and how to interfere with that to help stem cravings. We don't really have as much, um, you know, in the way of assistance for the receptors in the brain that get involved with psychostimulants. There's still lots of evidence that talk therapy, and CBT and DBT as behavioral therapies work pretty well for people with meth, but it's just really, really hard to get through the cravings for methamphetamine. So,
And
um,
naloxone doesn't work with meth,
no,
right? It's only for opioids
that's correct.
and
Yep.
also for fentanyl.
So fentanyl is a synthetic opioid. So yes, it does work for fentanyl, but depending on the how much somebody has consumed, it might take extra doses that come in a kit. So when fentanyl really hit the rise in our region, we started giving out more than one naloxone kit to people because it could take 3 or 4 doses, and there are only two in each kit. So yes. But I will say we've made such a dent in Washington state with opioid overdose that it's now not the number one overdose death um, drug. It is back to meth being, the overdose death attribution, top attribution, which is also to say it's hard to know when there's a stimulant overdose. It often just looks like a cardiac event, or endocarditis, or something else that's going on with regard to the heart. It's really kind of easy to know if you've got an opioid overdose because it looks a certain way and it responds to naloxone. So,
Can I ask how, it's a grim question, but what does an opioid overdose look like?
so people, because so what one of the things that opioids do is they create this tolerance effect. So you need to use more and more of the drug to get the same or chase the same feeling you once had the first time you ever took it. Um, and then if you interrupt that tolerance effect for any reason, like say you're in jail for 10 days, you cannot go back to what you were using before, or you're going to, shock your nervous system. So it depresses breathing and respiration through slowing down the diaphragm. And an opioid overdose, everyone always thinks of like the end result, the person is dead, but it really takes hours to develop unless it's fentanyl related. A fentanyl related overdose death can take maybe something like half an hour to happen, whereas without the presence of fentanyl, it could be more like 4 hours, 6 hours, 8 hours over the course of a night. So someone will, be unresponsive, and I tell everyone, you make a fist, and you get those knuckles right on someone's sternum, and you rub as hard as you can with your knuckles on that sternum, and if they don't wake up, they're overdosing, um, because you're going to wake people up. You don't throw water in their face, you don't stick them in the shower, you don't want them to drown. You can look at their nail beds to see if they're not painted nails, if they're cyanotic, so like they're turning blue, their lips. People of color don't necessarily show the same kinds of symptoms for cyanosis, so you can't always go on that. um, but if they really won't wake up, then just go ahead and give them naloxone. um, they should wake up pretty much right away. They may be kind of irritated with you for interrupting what they say was a wonderful high. But we did a survey with law enforcement, and asked them what were people like when you woke them up with the naloxone that we gave you. And the vast majority of people were just worried. So there were very few people who like woke up really hostile and got aggressive. It was like the second to lowest response. Any rate, all of this is to say is I do wish there were more help with meth. And the good news is, Chuck, that House Bill 1499 came out last week, and it decriminalizes all personal level possession and consumption in the state of Washington, including meth, um, everything else, LSD, cocaine, all that other stuff. And you're going to sit there and say, whoa, wait a minute, decriminalize. It doesn't mean legalize. It's still not legal to use those things, but you can't go to jail just for having used them. So it's moving people, it's kind of taking the LEAD program and making it go statewide. So instead of a hose, we have like, a garden hose, and we have now a fire hose. So I hope that's going to help get people into treatment and case management for meth and psychostimulant use as well, instead of just a focus on opioids. I'm sorry for the really long answer.
Great answer. Zidane had a question that she sent to me, which is,
Oh.
do you want to ask it, Zidane? Okay, perfect.
Go ahead.
Yes, perfect. Well, this is kind of just I'm speculation necessarily, but I'm curious about what you see as maybe differences and or similarities between rural and urban communities as it relates to, HIV, opioids, all of these sort of things, like all the problems that Blue Mountain helps with, and just that we see in our community as it relates to drugs. I'm just curious about what you see as the difference.
It's a counter narrative. Okay. We're all the same. We have biased people here. We have awesome people here, just like they do in King County, Pierce County, Thurston County. But we have far, far fewer resources. And so when I try to advocate around increasing the robustness of our resource infrastructure. So if someone doesn't want to, like, there was someone who had HIV and he went to the dentist, and the hygienist was like a second cousin who was like, oh my God, I can't believe you have AIDS and you never told me. And he was like, I didn't say I had AIDS. And she said, well, why are these your medications in your medication list? But there's nowhere else for him to go, because that's the only dentist that takes the insurance that the state gives to people with HIV, right? Or, later after 2014, that's the only place where Medicaid patients can go.
Mm-hmm.
So if he'd run into, he wouldn't have run into that cousin, going to one of 17 different dentists that take Medicaid in Seattle. Right. And two, if he had 16 other dentists to go to. So that's really where differences start to come in. It's around who knows who out here, because everybody knows everybody. Mm-hmm. And it's about like, that we don't have alternatives when we need a service, or we just don't plain have the service.
Right.
I remember talking to Senator Mike Hewitt, a long time ago, and saying there's not enough resources for people with HIV here. And he just looked at me and he said, yeah, Everett, there's not enough resources for people with cancer. Yeah. And I'm like, well, HIV is not worse than cancer. Like, right. Whether you have cancer, you have HIV, that's not the point. But I agree. People with cancer deserve all the resources that they need in a way that they can access them and not have to take a 6-hour car ride.
Right.
Yeah.
Can I ask another question, Leaf? I was also eating my dinner, which is why I didn't have my camera on, because I felt awkward about just eating food. So
I know, I understand.
Folks at home. I'm curious about, and not to get maybe a little political, I guess, but I'm wondering if if you see any hope in the Biden administration, just as it relates to drug overdosing, just all that. Like, do you see any have any sense of hope for what he might make policy-wise that might affect the work that you do in Walla Walla residents as well?
Better, worse, stays the same? Question.
Well, let's talk about a specific example. To be able to prescribe buprenorphine is listed as a controlled substance in our national schedule of drugs. And so it's under the purview of the DEA, the Drug Enforcement Administration, the people who, the narcs. And the Trump administration had agreed to stop requiring this very long and involved process for being able to prescribe buprenorphine to people, because it's a partial opioid, yes, but it's a partial antagonist, is what they call it. So you can't get high off of buprenorphine, and some people have tried and frustratingly reported that it didn't work. And it's also really hard to overdose on buprenorphine because it's a partial opioid. So we were happy to hear that the Trump administration was going to stop requiring a 20-hour course for prescribers, but they didn't do their due diligence around ending that requirement. So if you need to get this special like X waiver to be able to prescribe it, and you take away the only mechanism for getting the X waiver, then how do you know anybody has the X waiver? That, you still required that down the pipeline of the process. So they weren't getting rid of it in a coherent way. So when the Biden administration came in, everyone just assumed that they would say, yeah, sure, we don't need to have this waiver process anymore. And they said, well, they didn't do it the right way. So no, you still need to have it. And we're going to end that rule change that the Trump administration had. So now everybody's mad at the Biden administration for saying no to what the Trump administration has said yes to. But they didn't say yes to it in a way that made sense. So, what we need to do, no matter who's in office, is effectively advocate for these groups of people who, are really underserved and don't have a political voice, and help them create political power for themselves. So, I'm not saying that the political parties are exactly the same, but that the positionality of people seeking redress and progress, is pretty much the same no matter who the elected folks are. Does that make me sound like a 501c3 or what?
Perfect.
Yeah.
Well, we're at the end of our covenanted time, and I'm so grateful for you, Everett, and for the work of Blue Mountain Heart to Heart. So grateful that we have folks advocating for our neighbors, to be those people who are there for them when all other bridges have been burnt. In the church, we really feel that. We feel that. It has deep resonance for me. So I'll be thinking about that in the weeks to come. You had mentioned your website as one way to get involved, just to check out your work and give. That website is linked in the email that went out to parishioners today, and I'll make sure that it is also linked on the church webpage, so that if you feel called.
And there's a volunteer form on there too.
Oh, so. Wonderful. Cool. Like, what kind of opportunities to volunteer?
Oh, anything and everything. Filing and helping us send out mailings to folks, or doing we do vaccinations, not of COVID yet, but we will probably be doing some COVID vaccinations down the road. So if anyone is like a retired nurse, if you still have your license, we're happy to get you involved. So there's lots of different things folks can do. Yeah.
Oh, and a thank you from Cindy, who says, thank you, Everett. You are such a gift. And you are. So thank you for the gift.
Too, Cindy.
Thank you. Thank you on behalf of Cindy. She is indeed. So on behalf of the whole community, thank you for your time. And I hope that this conversation continues in our congregation, and for all of our guests. Take this conversation out into your circles, and let people know what Heart to Heart is up to. And let's start destigmatizing our neighbors. They need our help and our understanding and our love. So we'll work on that. Thanks, Everett. Good night, everybody.
All right. Thanks, everyone.
Next month, second Tuesday. See you then. Bye.